she does not have to quarantine upon return, because we believe that it's hard enough to be a kid with parents who live in 2 different states than to put the stigma on that child that upon return they have to be treated with this quarantine, which is concerning to people because it's basically saying that kid could have exposure and we don't care, which is not what we're saying. We're explaining to families that child has to be very protected and kept apart from any public activity, but that the visiting the parent is important to his emotional health. And I wonder if your schools have grappled with that yet, because it's a hot topic and it's not easy.
Rena, this is Soph. I do have a question. This is a great spot if you don't mind me butting in. I have some families that the child was with the non-custodial parent all summer in a red zone. They need to quarantine when they come home if they are not coming home until before school starts.
Yeah, see, that one feels like it could use some team-based care as well, because that example, I would suggest that there should be better planning to bring that child back in a way to get clean from the red exposure for the 14 days or the 7 days and the test, which would require really collaborative parenting, right? To say,
exactly,
we're going to go, we're going to get you home a little sooner than normal because it's an extraordinary time. Because a whole summer in a red zone is different than the weekend you need to visit your dad in Boston, right?
Right.
It's just a cumulative exposure that makes me want a different, that wouldn't be what we're talking about with this cross-state travel for kids in custody. We're talking more about like the week with the dad, the weekend with the mom, and we're just driving to Boston. So if you have any ability to bring in like the medical decision making, like that would be a great example of how you plus the parents plus the pediatrician could say what makes the most sense. And it may be that the child should stay out of school that first week and get a test. So this is really imperfect, and I know you already know this deeply, but we're so attached to the social emotional needs of kids that we can't get so blinded by this pandemic that we say every kid that goes to see a parent has to then stay alone in a house for 14 days. That's just heartbreaking. Chanting, my music teacher asked about group chanting. Do you know if the question's been asked? Yes, it has. Chanting is not allowed. So we don't know much about why kids don't spread this virus. You know, we've talked a lot about this. They don't really efficiently or effectively transmit, especially the younger kids, but it has something to do with the force of their coughing and speaking is the current theory with infectious disease specialists. So singing, chanting, yelling have more force. So that is really off the table, which is unfortunate. Can kids recite, chant, sing common learning songs in class with masks on, distance 3 to 6 feet, songs to learn the months of the year? Yeah, so we're really sorry about this, but it is better if those are spoken. Because again, the force of singing, and what's unfortunate about this is it's really, the recommendation is coming off of one major terrible outbreak at a church choir in Washington State back in March. So it doesn't have a ton of relevance to kids, but it's where we got all the energy around the concern about singing. And what we've been saying to the music teachers, because they've been asking and really great partners, is if we can get more evidence that this can be done safely, we will figure it out and amend our guidance. But right now there's no singing. You can sing outdoors to your heart's content, 6 feet apart. Okay, so Clayton, let's pivot here because
so I've made some more slides. So if you unshare your screen, I'll share my screen, and then you can just keep reading them, but it'll be off of the newer slides that I just made, okay?
I hope I stopped sharing, but I probably didn't. Let's see.
I think we should be set. Can you see my screen now?
Yes, I can.
Okay, and then just one other thing, I didn't start recording until about 5 minutes ago. I have to apologize. I was trying to do a whole bunch of different things, and when I hit the record button, it did not start. So all the questions that we have, we'll have to go back and type some answers in so we can get those out, because we're not going to have a recording for most of this conversation today.
Okay, well, we'll keep trucking here. I just really want to comment on how incredible you all are, because these are sort of strength-based questions. I can tell that you're trying, and everybody's wanting kids back with their experiences, and this feels really sort of hopeful that we're going to try to figure this out together. So really trying to get clarity around the common cold. So child starts with a runny nose, lasts for a few days, then may develop cough, which can last for a while, more than a week. Clarity on this process. We keep them out from an onset of runny nose and then the cough. They can miss 1 or 2 weeks. This is all fever-free. Yeah. So a couple things. One, we're hopeful that kids are going to have less of these prolonged respiratory illnesses this year because of masks and hand washing and other people staying home when they're not well. So there's Pollyanna, hopeful Brina. The second thing is this type of kid who has a short-lived runny nose and then a prolonged cough, this needs a conversation with the medical home, because if you could ascertain that this child actually has a reactive airway, meaning a diagnosis alternative to COVID, then he or she could return to school with the reactive airway /wheeze /prolonged cough /asthma and return to school with that awareness and potentially some of that treatment, maybe an albuterol inhaler. So, or that child could be noted that he was exposed to someone known to have traveled, or maybe had an exposure to someone with COVID, and that person could be tested. So this is that group of kids with the prolonged symptoms that needs medical home teaming. And it is a big pain in the neck for families. This is a kid that used to go back and linger and cough, but I'm not clear that was a good idea. And so I'm hopeful that you can get an alternative diagnosis from the pediatrician here. And if you can't, they are going to have to stay out till they're symptom-free or get a test, which we're doing a lot of talking with your pediatric medical colleagues about anterior nares testing in the primary care offices, which we have good supply chain for right now. And maybe we can get more kids screened out for not having COVID and get them back. Okay, next slide. We're providing face shields for staff working with students who have hearing loss need to see their face for speech and language services. If the staff needs to see the student's face when working with them, is it okay for them to remove their mask, wear a face shield, then they sanitize, reuse for other students? Yes. Briefly. I would rather you had a face shield plus, well, I'm wondering how we're doing with the supply chain of masks with the cutout for the seeing of the mouth. If that is not available, then you would like a student to see your mouth, you should stay 6 feet, put the face shield on and do the work. If you can't stay 6 feet, it would be way better if you were masked. And the sanitizing of face shields is addressed in our guidance, but it's very reasonable to reuse. Okay, next slide. We also have desktop plexiglass. Does the student need a face shield, or as long as separated from a staff by plexiglass, can they take the mask off? So interesting. So plexiglass works if you're really, if you've got 2 feet or more above the height of the student in some studies. So I would still prefer the mask with the clear cutout or the face shield and the plexiglass. I think we're trying to keep sort of adding up a risk. So I guess in that circumstance, I would feel better because you've got face shield. and plexiglass. If it has to be plexiglass alone, I'm not sure. I also don't like the idea of sort of intermittent times without masks, because I think it gives people sort of a permission to start doing it more often. Okay, that one I answered. Thank you, Clayton. I did that one. Folks have been asking me about performing temp checks with a non-contact thermometer on the wrist instead of the forehead. This is great. We got this question by email yesterday, and my team is amazing at package inserts now and manufactures research and intention with thermometers. So if it is not used as a wrist thermometer, it is not, you cannot decide to do that. If there is wrist thermometer technology that is been studied and you want to bring forth to our team, we are open to it. We heard this remarkable thing yesterday that folks feel when they point the no contact thermometer at a child's head, it felt like a weapon. I feel that is that the user of the non-contact thermometer can figure out a way to come from the side or make it fun, or I don't want to start seeing things like that as weapons, but I also appreciate your observations. So Sharon Lee, do you want to weigh in here? This whole wrist, I have not seen good studies on wrist temps, but that doesn't mean they don't exist.
We had a fabulous childcare provider about 4 months ago send us some research from China, and we were unable to read most of it. But it was one tiny study and it made sense, but it's not been restudied or vetted. So.
Okay.
That's all I've heard.
I get it though, yeah. What accommodation do you suggest for a student who's legally blind, a fall risk, needing a staff closer than 3 feet at all times? Okay, so this student needs a special education meeting already with medical home, the caregiver, you know, the aide, the school nurse, and the family, because I need much more information. I think that the person that's going to be one-on-one care with any student, including, because most one-on-one time requires closer than 3 feet, that person needs at least mask, maybe intermittently. Sharon Lee, weigh in here, maybe goggles, depending on child's behavior.
Yeah, that's all
face
part
shield
of the
on top of the mask. Yeah.
assessment with the family and maybe with the medical provider, but certainly with the family and the special ed person, is to the age, all of the factors that go involved, and that one-on-one may need a higher level.
That's right. So, I mean,
and that should be
hope
part
is
of the
going on.
Cost.
That should, right, exactly. I hope that there are special education teams already thinking together. And remember, I've talked to you guys for years about my concern that school nurses are not on every IEP or 504 meeting, and this is our time to say that an essential member of a team is our school nurse, so that when we're done with this pandemic, we have that base now to say, do you see this role? Do you see the importance of team-based care? Do you see how school nurses are the conduit to our pediatric medical homes? So. Okay, next slide. I've noticed a lot of vented masks on campus. Yeah, I do not know anything about vented masks, which to me means they're not approved. That sounds risky. We don't even really we're not allowing the goggles with the holes on the side because that defeats the purpose of
vented masks are addressed in the first link I put on from Drs. Lee and Raska. Vented masks are not recommended, not allowed in schools.
Okay, standardized letter to and from provider and school nurse when student is sick. Is it available? Has it been shared? Yes, it's available. It's sort of been shared. We gave it to your school liaisons. We're hoping it's part of the community-based conversations between you, your school liaison, and your medical providers, because it's a communication tool more than a letter. And we did a little formatting today to make it better. Clayton suggested don't forget the kid's birthday. We heard from a few folks that school nurses thought they were the ones in charge of diagnosing. So we're trying to make it clearer, but my messaging to you is get the draft, which we can send out. It's not even a draft. Get the template. Talk to your medical providers about how to use it. Because at the top we say a note to parents, a note to school nurses, and a note to medical professionals. What's the thing? Because what we really want is for the medical homes to use the algorithm to circle which part of the branch on the algorithm is the pathway for this kid, meaning he was tested and he went back. He was not tested and he got better, he went back. He was not tested, we found strep and he went back. So there's a lot there, but yes, it exists. We're not making it perfect because we thought it was going to be used by school nurses and pediatricians to figure out their own way that you want to communicate. Because as I've said to many people, I don't know if you want phone calls, fax, parents to carry pieces of paper, and it's going to depend because not all kids are going to the medical home. Some of the kids are going to talk to a triage nurse at the medical home. How does the paperwork work then? And so we will get that to you through Sharon Lee, and also be in touch with your school liaison if you haven't already. Okay, I think we answered the legally blind question. That's about special education and teams. Some of our SPED team is suggesting a student who cannot keep a mask on should not be in school. We do not say that in the guidance. We are very clear that there are equity principles at play and that we need no standard assessment there. This has to be a team that thinks this through together. What is the student's diagnosis? Why is he not able to wear a mask, he or she? What is the child's age? What is the child's exposure? Meaning, where are they in the school building? What is going on with their instruction? So we, by design, stayed away from that type of definitive statement.
Dr. Holmes, if I could just add to that, there are 2 documents that were posted in the last few days on the AOE website under special education. Yes. And one of those 2 documents does talk about students that are unable to wear masks and the methodology used to figure out what the best response is for that. So if you go to the AOE page and scroll down past the Strong and Healthy Start section that says special education, and that information there might be helpful.
Also, the guidance in the PPE document from the health department includes inpatient psychiatric care and group home settings. So if you just look above or beyond the school guidance for PPE, there's guidance there that would be relevant perhaps to your setting.
Yeah, that reminds me to tell you all that we're finalizing a document this week about medical exemption for mask wearing, and the spoiler alert is there's almost no medical exemption, like truly, and we have pediatric pulmonologists, pediatric intensive care doctors, hematologists, oncologists, everybody at the Children's Hospital is saying, nope, not a contraindication, and if a kid with asthma or another respiratory condition is not tolerating a mask, they need to be seen by their medical home because it means the care is not, they're not feeling well enough and they need better medical management, but that doesn't mean no mask. And I'm sure you're getting in a pickle with this because of the sports teams. There are a lot of parents who want their kid exempted from mask wearing in the fall sports. And our pediatric colleagues are getting a ton of pressure to say, oh yeah, Johnny has a little touch of asthma. So that's in the medical arena. When we're talking about children with special health conditions like autism, that's a different conversation that requires a much different team. I am not talking about, you know, sort of the intellectual disability, cognitive impairment, behavioral challenges. That's a also important team-based care. I'm talking about the idea of someone saying, I can't get air because I have asthma, would be the most common. And the pediatric pulmonologists are very engaged with us that that is not a reason to not wear a mask. A student with a history of airway issues, several surgeries to reopen that parent state have been cleared for school but can't wear a mask for long periods. We had hoped for use of a face shield and possibly a mask for short periods. Hearing you thoughts on face shields, do you have other suggestions? So you guys, sorry for the broken record, but this student needs a meeting with, if they have had multiple surgeries for airway, they have pediatric pulmonologists, they might even have an ear, nose, and throat specialist. I bet they have an incredible general pediatrician. So I don't want you to feel like you have to make accommodations for a student without a team, because once I don't know what an airway issue would be that would lead to multiple surgeries, but it may be that that child does need an accommodation which can be made with a team. I'm wondering about headaches. I know I see students all the time, and a lot of the time not enough fluid. Headache is a COVID symptom. Do I have to send them home no matter what? We love your clinical judgment as health professionals. This is why we love school nurses. This is why we need one in every building, and you know that's my mantra. So this is the absolute clinical decision-making that goes on. When you are working with a student and you know they don't drink, they're not hydrated, then hydrate them and then see what happens. Or a child that has migraines because in the fall they have ragweed allergy and they experience headache as one of their symptoms. You know that because you know them and you know their pediatrician, you've talked this through, and you're going to be able to make the sort of accommodation for that without assuming every headache is COVID. So there are a few symptoms like this where they're not high on the list of COVID, but we can't exclude them from the list because they are, when they're new, so when symptoms are new, we need kids to be excluded. And I guess a new headache in a kid that you've never seen in your health office before would be enough of a concern to send home. But a dehydrated kid that you know never drinks water, I would really want you with that kid to get him well. Okay, this is to what Sharon Lee was just saying. What are your suggestions for crisis team? We have had students become dysregulated and violent. They typically need assistance from crisis team. So we have some pretty solid resources that, again, I always count on Sharon Lee to be my chat box friend, but the Department of Mental Health and the Agency of Education put together very solid, with public health, some documents on the special teams around kids with dysregulation and behavioral challenges. I see facials being a frisbee. Oh, I see. Yeah. Yeah, that's all. I mean, there are definitely students who the crisis teams need to read this guidance about and then make some pretty strong decisions about the safety of themselves, the care team, and then others. This was added to the fall sports program document yesterday. Students who have a medical or behavioral reason for not wearing a facial covering should not be required to wear one. These decisions should be made in partnership with healthcare provider and a school nurse. Okay.
So that was the only language that was added to that document. I just wanted to make sure. I didn't know if you knew that. That was posted yesterday. And
no,
that kind of goes back to what you were talking about a few minutes ago.
Yeah, I don't love that guidance, but I like part of it. So I'm not sure who wrote that. I like the partnership language, obviously. Just leading with medical behavioral reason for not wearing one, that's too vague. And what we should lead with is students that are not tolerating the facial covering need a team meeting to determine why. Why? There are almost no medical indications to not wear a mask. I just want to state that again, because the elite athletes and folks, they sometimes wear a mask as a way to build up their respiratory capacity. Like I think we're really wanting the right information for people. There aren't medical exemptions. Rare. Okay, I'm looking at my watch. 2 more questions. Can Dr. Levine talk about the masks in schools? Oh, at the press conference? I feel like he addressed it Tuesday. I think I just told you there are limited medical reasons, and that way we could reference what we respond to parents. I'm okay sending you another state's experience with a medical exemption document to show there are no medical exemptions for masks, but I've got my subspecialty team looking at it right now to make it Vermont, and I was hopeful it would come out before the Labor Day weekend, but I have to be respectful of people's time commitments. So we will have something for you, but it might not be the start on Tuesday. But yes, I feel like he's done a pretty good job there. It's a fascinating journey of the masks in schools, which are required, then the decision that fall sports were going to happen, and then masks were required, and then recognizing kids play rec sports and those other club sports that were not requiring them because they were following our summer guidance, but it's all aligning. We're not going to let it be this confusing for very much longer, and the commissioner meets with folks all the time about getting it right. One more question, I think. Health department says we should be able to delegate even caring for symptomatic students, and therefore, if a school nurse is absent, schools can still be open. There's no one in my school I can delegate care of a symptomatic child. That is too much of a COVID risk. NEA would not be okay with this. Okay, this is a really important question. This always happens at the last question. Do you guys know the healthcare saying about the doorknob question? When you've been with a patient for an hour answering lots of light questions, and then you stand up and and they say, wait, doctor, just one more question. I need Sharon Lee on this one, because we're not in utopia where we have school nurses full-time everywhere, every day, and a pool of school nurses to sub in. So no utopia, it's still best practice. But we've developed, and we have very good language around delegation in our school nurse manual. Sharon Lee can maybe pick this one up for me. And the risk of COVID isn't any greater. A sick kid, will need more PPE for his or her care while waiting to be picked up. Does anybody want to help me with this one? I hear you, and I don't really want to evoke the NEA, because I don't know that we're asking the delegation to be in the teachers union, right? There are other staff that
this is really
participate in the delegation.
This is the Board of Nursing guidance. Just a minute, Claire. This is really, it's the same delegation issue as it has always been. It's a nursing decision about what you can delegate. If you have a school with no school nurse and you're training the delegatee, then when those symptoms come in, the student goes home. There's no place for the delegatee to be making an assessment. If the nurse was there and could work through that algorithm, that's fine. But that's what that's what childcare providers are doing. They're making these decisions all day long. We know because we're on the phone. And your delegatee could call us.
Yeah, no, I think the go straight home is pretty clear. What this question's asking is harder, though, is how does a person wait with the kid who's been isolated, who's a non-medical person? What is the PPE for
that's what
person
the
who's waiting. Yeah.
that's what the training of the guidance. I think I put it in this chat. There's a training document, or maybe I put it in somebody else's email. But there's guidance from the NASN, NASNIC, and NASNIC document has 3 links for training. That's you train that person, the secretary, to put that equipment on and bring the child to the space, and the child waits with their surgical mask on, and they go home. It's,
Right.
we're not asking them to do anything very complex other than take a name and take a temperature if you delegate that to them.
So we are at the end of our time, and I am so appreciative of all the questions, because we all have them. So thank you for those who have asked them. And I'm going to end now, but I'm also going to share with you that I intend to be sitting outside with my students who are waiting to go home to be picked up, or whoever. If that is at all possible, anything we can do outside is much safer. We don't have the risks, and we don't need the PPE, and we don't have to take people away from whatever their other job might be. We can't obviously have a student out there by themselves, and that's not meant to seem like I'm taking this lightly. But we have to be creative, and if that's the best mechanism that we have while we're waiting, then let's do that. So I know you all are anxious.
Can I, let me, so if I just want to end with one thing, I've forgotten, maybe not, but to tell you all that tomorrow's my last day as the MCH director for the health department, but I'm staying on as a medical advisor to the health department, to the MCH division. And I realized in all this craziness with COVID, I didn't really share clearly. I was hoping it would be sort of invisible to people, because I'm moving over to the Department of Pediatrics to be part of their Vermont Child Health Improvement Program, which I hope many of you know about. That certainly that call that we host. This was a pre-COVID plan. I was supposed to become part of the faculty and do medical student education. Then COVID hit. It obviously wasn't the right time to abandon my public health colleagues. So we've created this new structure where I'm a medical advisor. I still work for the health department while I'm still working at the university. But in case, so Elisa Stahlberg, who's our amazing deputy director, is stepping in as the MCH director. So it's certainly not, I really don't think it's a huge shift in the way I work with you all, but I didn't want you to get some weird rumor that Brina Holmes left. I'm going nowhere. It's just I don't have the same title. So I'm here for you. We can do this again next week. Like, let's keep this energy. Oh, and our team, which was 4 public health nurses for the whole summer, well, since March, is now 8. We've doubled our capacity to answer your questions, and we're so excited. There's a little bit of onboarding to get some of our team up to speed, but we really are developing as much of a bench as you need, so we've got your back every day, all day for the next weeks and months ahead, because here we go. I'm so grateful for all of you and the kids